numbers 1, 2, or 3 where you are in this process of becoming a Medi-Cal community supports provider. Be talking about the Medicaid basics, the Medi-Cal basics, just so that we're all on the stage and what we're on the same page when we're talking about what it means when we say the word Medicaid, right? We'll also be talking about what's happening not only nationally, but in California in particular. And we may even spend some time talking about by county how things are being affected from the transition to this benefit opportunity. Also, we'll be talking about our enhanced care management benefit opportunity. So we'll go through each benefit that's available to be billed potentially under CalAIM and what those are. And then we'll be talking about how we'll be integrating Medicaid potentially as a funding source, what it means to look at the contributions, what it looks like administratively for your organizations when it comes to just the basic documentation, billing and contracting requirements, and also the implications for your organization if you choose to go this route.
As Ambrosia said, today's session, today and on the 25th business planning, are for those of you that are in that 1 or 2 stage of the category where you are still exploring what will it cost, what will it take, is it worth it? What do you need to put in place over the next few years to make things fiscally sustainable? The sessions that begin with the Money Matters session and then through the end when talking about documentation, policies and procedures, compliance, and electronic health records, that will be most relevant for those of you that are in 2 and 3. So we're starting out high level today. And I just want to encourage you, if you're one of those that said, hey, we already have contracts, stick with us. Also know that I know you have lots going on, so know that this is being recorded. If you already feel like you have a strong sense of the overview of Medicaid and requirements and how things change receiving that funding stream, feel free to also know that you don't need to have multiple team members on if you already have a contract and you're not looking for the basics. So we know that multiple systems and massive federal and state funding sources overlap in terms of serving people who are unhoused. What we don't often talk about is the buckets of funding and how they compare. When we look at healthcare and healthcare systems compared to homeless services and housing systems. So I want to give a tiny overview of why we are seeing this shift in housing and homeless services shifting into or being brought into the healthcare service space. It's a trend that is not going away. I'll say that since the early 2000s, healthcare has been very interested in understanding the cost savings that's possible and the health improvement that's possible when people become housed. More than ever, now with federal leadership from the Centers for Medicare and Medicaid, we are seeing state after state after state change their state Medicaid plans to include homeless services that help people to find housing, get housing, move into housing, and stay successfully housed because they see that as a direct benefit towards people's health and direct cost savings to the healthcare system. So there are multiple reasons that the healthcare system as a system is interested in this. So we have seen, since the early 90s, there have been pilots that have been looking at the cost of people who were experiencing homelessness on healthcare systems in terms of dollars and strain to systems related to emergency department visits, overnight hospital stays, things that could be prevented if someone had a home where they could recover in or a home where they could store their medication and not then have certain crises that send them to the emergency room. So since the 90s, there's been evidence that's been building up, research studies that have been getting attention. And finally, in 2015, the Centers for Medicare and Medicaid released an informational bulletin saying, we have seen enough demonstration and enough states use creative and innovative ways to pay for housing related services that we are going to make it public that states can choose to use Medicaid if they amend their state contract to pay for housing related services. So we initially saw California do that with the whole person care pilots and health homes programs. Those now are being rolled into CalAIM, which is a new transformational and innovative endeavor that the Department of Healthcare Services is undertaking, and it involves lots of different changes. And there are two small pieces that we're going to be digging into deeper today. But what we've seen is around the country, many different states are adding these services, and in some cases, they are making them benefits. And when we talk about a Medicaid benefit, that means it's an entitlement. So if someone is eligible, they are entitled to receive that, and the state is obligated to pay for it. That is a benefit. In California, community supports that are housing related are not a benefit. So they are optional services that managed care plans can pay for, but they are not an entitlement. So if someone is determined eligible, it does not obligate the state to pay for every single person's service. So we're going to break down what that means, and then what that means as a provider, looking into, does this make financial sense for our agency? Does this make sense for our staff to take on? Will this best serve the people that we work with? And does it align with our mission? So in terms of just federal budget, big picture, the Centers for Medicare and Medicaid, just one part of the Department of Health and Human Services, the US federal government, had a budget of 1.4 trillion in fiscal year 22. When you compare that to HUD's budget, and that is HUD's budget for everything that HUD does, the Housing and Urban Development Department, their budget was 234 billion. So we are talking about two different federal funding streams that each right now have their own compliance measures, their own audits, their own expectations of how their funds be used, their own legal definitions and terms. But one is much, much, much bigger. And so as homeless service providers are entering into, or as actually sometimes being pulled into healthcare, that does mean that there's going to be a lot of change happening in terms of what does compliance look like? What does funding and payment look like? What does documentation look like that has this history in healthcare that may be very different from what we're used to with HUD funding and COC funding? So this is just a snapshot. The purple states are states where there are already operating some sort of Medicaid mechanism to pay for housing related services. The teal colored states are those that are in the planning stage. So the state Medicaid agency has said, we are very interested in this. They're working on legislative language to submit to the federal government, Centers for Medicare and Medicaid. And then those that are in that yellowish green are in negotiation. So they've submitted something to the Centers for Medicare and Medicaid, and they're waiting for the special terms and conditions. They're figuring out all of the legal ways in which they can pay for housing related services. So this is not going away, as I said, but we are calling this the Medi-Cal Academy and not the Community Supports, Housing Related Community Supports Academy, for a reason. And that reason is that each agency is at a different place in a different county, working with different managed care plans. There are different eligibility and standards and payment rates depending on the county and the plan that you're contracting with. And depending on what your current funding structure and your current staffing structure looks like, it may make total sense for one agency to go for it all, and it may make total sense for another agency to say, we're going to sit back and make a business plan and figure out what we need to do to get ready if these compliance changes and documentation become the norm. But we're going to sit back and observe and just get some planning done. It may make sense to be having a small contract or a subcontract with your county. So we want to support you in that decision making, and but just to have that lens that Medi-Cal and the compliance aspects that we're talking about now, some of these may apply for the managed care plans you're contracting with, and some of them may not at this point. But if we continue to go down the path that all of these other states are going down, it will mean that more and more healthcare systems and healthcare funders are going to want to be paying for these social services that are social drivers of health, and housing, particularly in California, is a top priority. So what does that mean? Social drivers or social determinants of health in the healthcare sector typically come with their own assessment tools. Some of these assessments have very similar questions to assessments that we're used to in the HUD and COC funded world, and some of them look very different. There's a big learning curve for healthcare funders and payers like managed care plans to understand all the nuances of housing and homelessness and the experience of being unhoused that you all have been living, working, and breathing all these years. And so there is going to be a lot of dialogue, and you'll see a good number of changes happening during this trial period of 5 years of community supports, where assessments might change over time, eligibility criteria may change over time, as managed care plans are trying to best serve the most people who are experiencing homelessness as possible while still saving costs. So while still avoiding unnecessary hospitalizations, emergency department use, et cetera. It also means that referral systems will change, or there may be additional referral avenues to you. So managed care plans and enhanced care management providers could be referring individuals to you that are unhoused, and they may or may not be within the target population that you're currently working with. If you are working with a COC funded program and you're primarily serving people who are referred to you when they are experiencing chronic homelessness, if you enter into a contract with a managed care plan, it'll be important to understand what the referrals structure, frequency, and target population will be coming to you with that contract. There will likely be outcomes that are expected that the managed care plans are trying to target that are health related. So not only hoping that someone will successfully move into housing and stay housed, but also then looking at health outcomes. And that may or may not involve your staff being involved in some of that care coordination. And then there's lots of new investment happening. So there are new grant funding opportunities. There are new incentive payments that the managed care plans are receiving from the state, that then some of that incentive payment needs to be then pushed out into the community and to providers. So there's going to be a lot of funding that's coming down. So this means new opportunities and new challenges. What it means is for your executive leadership team, it may feel like you are bombarded with emails and newsletters and updates around new opportunities that may or may not need to be prioritized. It means that there is this new funding coming, but that there is limited time for coordination of how the funding should be spent. And that with that new funding does mean new sources of funding, possibly new expectations of how that funding is used or when it has to be spent down by, and new networks that you're going to be involved in. So our next session will be talking more about business planning and determining what makes strategic sense for your organization. But I want to just give this picture around some of the shifts or tensions that you might be feeling right now, and just again ask us to pause and breathe, because this Change with CalAIM Community Supports is a 5-year demonstration. So it is something that is going to continue shifting and changing. If you don't right now have a contract with a managed care plan, that does not mean you don't have an opportunity in a year or in 2 years. They are going to continue for ways to build out their networks of providers and continue to achieve the outcomes that the Department of Healthcare Services has asked for. I'll also say that a lot of those funding opportunities that have these limited windows for applying, we are now seeing that some of them are opening up to have a rolling basis for applications or reopening up because there is just so much that's coming down all at the same time with CalAIM. It's a lot. So you are not behind. And I just want to give that encouragement that this is going to take some years for everyone to determine how best to do it and what's going to work best for their agency. So some of the basics on Medicaid. It's a federal and state partnership. So Medicaid is half funded by the federal government and then half funded by the state budget. That means that each year the state in its budget proposes and estimates what it thinks it will cost based on last year's costs and any new programs or changes that it's making. And the federal government will match that at a 50% or higher rate for certain programs that the federal government incentivizes, things like smoking cessation. The federal government will actually pay up to 90% match for any dollar the state spends. So in it being dually funded, that also means that there is dual oversight, which means that there are legal aspects of compliance and regulations that come from the federal government, the Centers for Medicare and Medicaid Office of the Inspector General, and then there are some that come from the state. I say that because many of you are already in compliance with federal HUD regulations. And so this is going to be adding on a few other things that your quality assurance and compliance staff will want to be monitoring and aware of. And that is why we have several sessions dedicated just to compliance. There is significant state flexibility in what can be included in a state's Medicaid offering. So California, for example, has just expanded its Medi-Cal to be available for undocumented seniors over age 50. It's the only state to have that opportunity, and that is being paid for in full by California's state budget. So they have chosen to add on something that is unique to the state that is being paid exclusively by the state. The state Medicaid plan is something you may hear us referring to, and that is essentially the contract that the state has that is amended again and again and again and again. So many of these state Medicaid plans are thousands and thousands of pages long because they've been amended so many times since 1965 to add on additional services, to change expectations of what a provider needs to have training in, what it means for a primary care provider, what it means for a mental health provider, what licensing regulations are expected. Everything that the state will expect is included in its state contract with CMS. And so when we talk about funding for services right now that are being funded by state dollars, or maybe by local tax dollars, or maybe by HUD COC dollars, right now you are working on compliance with those local, state, and federal expectations of how you're using funding. Now, these additional services are expected to supplement your services rather than supplanting. So we're going to talk in the Money Matters sessions in depth about what that means. But what we're saying is it's not that local service funding will just turn off and then Medi-Cal will turn on. Instead, it's that there are some services that may align that you're already providing, but this Medi-Cal funding could supplement, it could make your program stronger. You may have the opportunity to lower your caseload sizes. You may have the opportunity to improve how, when, and where you offer services. You may expand to new populations, but it is not intended to replace your existing funding. Okay. I already touched on this. So Medicaid beginning in 1965, and then many changes have happened at the federal level, including the Affordable Care Act, expanding it to be available to anyone with low incomes. And then the 2015 informational bulletin that was so critical in saying that housing related services could be paid for by Medicaid. Some acronyms that you're going to hear me saying a lot. DHCS is the Department of Healthcare Services. That is California's department that oversees their state Medicaid plan. They are the ones that oversee Medi-Cal. They contract out some of the services to managed care plans. Managed care plans are health insurance companies that manage the oversight, manage who is authorized for services, manage provider contracts in terms of how much a doctor can be paid for doing a certain lab test, or for fixing a broken arm, or for determining who is in their network and ensuring quality and access. So managed care plans help to manage the state and federal dollars to ensure that they do everything and for everyone that they say they are going to in the contract, but do it in a way that keeps in compliance and keeps costs down. At the county level, behavioral health in California is operated by each county. And so the state Medi-Cal dollars then go to the county behavioral health systems. And so you also have providers who are county behavioral health or mental health providers that are billing and receiving state Medi-Cal dollars, but it's coming through a county contract rather than through a managed care plan. We have a PDF that it's quite long because there are so many acronyms in the healthcare and housing and homeless services space, but it has all of the acronyms that we believe you will want to know and be able to refer back to. That is going to be in the folder that is our Medi-Cal Academy folder that's available to all of you. We have it linked in the PDF that we attached to this training today, and we'll be sure to send it out after the training as well. So rest assured you don't need to memorize all of these acronyms right now, but just want to make you aware of these three since I'll be talking about them a lot. Okay, so now I'm going to dig in a little bit more into the community support services and the enhanced care management benefit. So as I said earlier, previously California had rolled out the Health Homes program. But you see this little orange arrow that says HHP and WPC, whole person care programs. And those were two innovations attempting to demonstrate for 5 years or to test out, if the state were to pay federally qualified health centers or health home providers funding to help engage, outreach, and serve people experiencing homelessness and provide housing related services through that avenue, while they also were directly paying counties to then contract for whole person care for those similar housing related services. They were comparing the managed care plan model through the county model with these two programs. What the state ended up doing is now in CalAIM, which stands for California Advancing and Innovating Medi-Cal, it is a new 5-year demonstration program where they are including a benefit for anyone that meets the eligibility criteria for enhanced care management, which is a type of care coordination where you will have a provider that is contracted with a managed care plan to be the enhanced care management provider. They will offer members a number of assessments around different social drivers of health. a food and nutrition assessment, a housing assessment, maybe an assessment around housing quality and air quality and asthma supports, really looking at the whole person, a sort of biopsychosocial assessment or number of assessments so that that care management provider can then refer to other community providers, whether it be bringing in behavioral health and mental health care, connecting the person to primary care, connecting them to a homeless service provider for housing related services. That enhanced care management entity is supposed to be the new hub of care for that individual. And this is a benefit. So this is something that anyone who meets the eligibility, the managed care plans are expected to pay a certain rate per person per month to provide this enhanced care management benefit to those individuals. Community supports are optional services that managed care plans can choose to add, and they can choose to add different community supports every 6 months. And then if they choose to stop offering a community support, they have to give a year's notice to the Department of Healthcare Services. So right now, all of the managed care plans in the state have decided that they want to offer these housing related community supports, which I'll go into in a minute. If for some reason, one of the managed care plans determines that this is not it's not working, people aren't getting housed, for some reason, they're no longer going to offer it, they can't just turn it off, but they can give their providers and the Department of Healthcare Services a year's notice and stop it in a year. So for that reason, they are really incentivized to get certain outcomes, to demonstrate that they have a really well prepared expert group of providers who are able to achieve the outcomes that they want, who are able to get people into housing and housed. And that's where all of you come in. So as I talked about funding, and a moment ago talked about the differences in how it's playing out in some counties, I want to walk you through this graphic. So the flow of money, and what that also means is the flow back of data and compliance, happens like this. So the Centers for Medicaid, Medicare and Medicaid, together with the state, fund Medi-Cal. Medi-Cal then contracts with managed care plans to manage the access and authorization and provider networks. And then managed care plans can choose to go into a contract with a county, a human service agency that is then going to contract with a community supports provider. A managed care plan could also contract with enhanced care management providers who then decide to subcontract with community supports providers. So there are multiple ways where you as a homeless services provider might enter into a contract or subcontract to provide these housing related services. You might approach or be approached by a managed care plan directly. You might be approached by or already in contract with a county for other homeless services, and now that county is in contract with a managed care plan, and so you may be brought in through that subcontract way. Or you might be approached by an enhanced care management provider who is trying to build out their referral network to know that if they have someone coming into that referred to them for enhanced care management that has a housing need, do they have providers that they can rely on to provide services? So there are multiple ways that you could be receiving funding, and that changes what you would need to comply with. So it changes your administrative responsibilities and your compliance responsibilities. For example, if you are in Los Angeles County right now, and the Department of Health Services has been paying ICMS, intensive case management providers, through local funds for some years to provide homeless services. Now the Department of Health Services is also in contract with some managed care plans to provide ICMS services. What that means is the Department of Health Services is worrying about submitting the claims, worrying about making sure things are HIPAA compliant, worrying about making sure that any referral they get, they know which funding stream to pull from. They are doing the blending and braiding and taking on a lot of the compliance and audit risks on their end. And then the providers, the changes that might happen there are maybe how you are doing assessments, where you are uploading those assessments to, and then what documentation is expected in terms of your day-to-day work with people. So if you are a subcontract, the risk that you hold as an agency may be less, but you're also not getting the full payment coming down from the managed care plan. In that middle line, when a community supports provider is contracting directly with a Medi-Cal managed care plan, that means that that managed care plan is expecting you as the community supports provider to understand what is expected for submitting your invoices or your claims, which there are certain elements in a Medicaid claim process that are expected federally, expected at the state level, and that managed care plans will look for and will only pay if it is a quote unquote clean claim. So if it's a perfectly submitted claim. So if you are in direct contract, you are then going to have to understand more about billing systems and HIPAA compliance and what it means to be a HIPAA covered entity, the pros and the cons, or the risks and the advantages of that for your agency. And so if you are the direct contract holder, all of that responsibility sits with you. I want to talk a little bit more about what community supports means when you hear the terms in lieu of. In lieu of is a term that the federal government, when they brought in managed care as an option for states to use in the 90s, there was a term here giving managed care plans the option of paying for services that were in lieu of or in place of existing benefits if those services were going to help the member more and were going to cost less. So they could pay for, really they could choose to offer an additional service in place of an existing state plan benefit if it was going to better serve the member. So it gave some flexibility. And what California has said with this is, hey, this is an opportunity for managed care plans to start getting into the social determinants of health. Why can't we have them pay for housing related services in lieu of emergency departments, in lieu of overnight hospital stays, in lieu of really costly services that maybe people wouldn't need if they were housed? What it doesn't do is it doesn't define for the managed care plans the breadth and depth of what in lieu of means. So that means that each plan is having to and has had to over the last year and a half wrestle with what does that mean in terms of who is eligible. Some are interpreting it at a population level and saying, you know what, the research says that overall people experiencing homelessness our higher users go more often to the emergency department, and overall they experience more overnight hospital stays. So overall, if we were to target anyone who's unhoused, we could offer this service to them and it would be in lieu of these other things. That's the most liberal interpretation, I'd say, that population-based interpretation. And there are some counties where the managed care plans are seeing it that way and saying anyone experiencing homelessness is considered eligible if they are through the coordinated entry system. There are other managed care plans that are looking at it on a person by person level and saying, does this member, is this service in lieu of something that this particular member would have needed? And so they are looking at it in a much more restrictive way. And so their eligibility criteria is being set much more conservatively. So some of the managed care plans you'll see on their websites, things like, if the member cost $50,000 in claims last year, or if they had 12 or more hospital visits in the last 12 months, or if they are experiencing chronic homelessness and have four medically, four diagnoses that are related to mental health and chronic illness and blah, 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 more and more criteria added on. So in those counties, it will take, I would say, a lot more analysis and a better understanding of the people you serve and their health conditions for you to know if this makes sense for you. Whereas in some of the areas where a managed care plan is viewing this as a really sort of a global population health approach, then you'll see a lot more alignment with the people you're already serving. There are many different community supports. There are 14 that the Department of Healthcare Services said managed care plans had the option to provide. Not all managed care plans are providing all 14. And the Department of Healthcare Services also said, managed care plans, if you have any other community supports you want to provide and you can demonstrate how they would be cost effective and good alternatives to existing services, feel free to suggest others. So while these 14 are the ones that were provided by the Department of Healthcare Services, there could be others that we might see managed care plans offering. Right now, they've got their hands full, so I haven't seen any offer additional community supports just yet. What we'll focus on in this academy are the 3 housing-related services that directly align with services provided by homeless service providers. There are other services that people who are unhoused could very much benefit from. So the post-hospitalization housing, short-term post-hospitalization housing, or sobering centers, or community transition services, or even medical respite and recuperative care services. These are all services that could very much support someone who is experiencing homelessness, but we're going to focus on these 3 housing-related community supports since these activities and services directly align with those that homeless and housing service providers across the state are already offering. So housing transition and navigation services. These 3 blue bucket headings are my own, just because there are so many activities that were listed by the Department of Healthcare Services. So just know that that's my thinking about how it makes sense to categorize them, but that's not provided by the Department of Healthcare Services. But all of these bullet points are. So this is directly from the Community Supports Policy Guide, which we have linked at the end of this slide deck. I strongly encourage you to save that policy guide. There is a lot of information that's going to be relevant for you as you make decisions or as you ensure that you are complying with the regulations laid out by the Department of Healthcare Services. All of these bullet points are the services that would fall under the category of the community support, housing transition, and navigation services. So you could contract with a managed care plan to provide housing transition and navigation services. And if you contract with that managed care plan, you would be committing to providing all of these services below. So for those of you that are just at the point of deciding, does this make sense for our agency? The very first place to start is to look at this list and see what % alignment do you have and what % of your staff time is spent on these activities. Does it make sense? If you have 75 to 100% alignment for certain staff, then it would absolutely make sense to think about housing transition and navigation services as being a funder. Housing deposits. So this is reimbursed funding for security deposits. It could be for first and last month's rent. It could be for assistance with paying back past utility bills or for other move-in related costs. That last bucket leaves a lot of room and a lot of flexibility. And so again, that is where your contracting conversations and negotiations with the managed care plan are going to be really important. And it may even mean if there are multiple providers in your county that you know are working with the same managed care plan, it might mean having a community meeting together with the managed care plan to talk about why certain move-in related costs are really important to include. Because since these are not benefits, these are optional services that the managed care plans can choose to provide, they can determine what is a reasonable move-in related cost and what isn't. And it may not be the same as what you and your expertise know is necessary to help someone with moving in. So again, if you currently do this, if your staff are spending time doing this, this may be one of the community supports you want to contract to provide. You're going to hear me saying again and again, reimbursed, reimbursed, reimbursable, Medicaid, and so that means Medi-Cal and Medi-Cal managed care plans. It is a reimbursed service, so you are not paid upfront. When you submit invoices and claims, it can be up to 90 days before you receive payment. And so we'll talk in our business planning about the importance of startup funding and some of the grant opportunities that are available, because this is going to be a big change for those of us that are grant funded to make when you're thinking about cash flow and paying staff. The last community support that we are focusing on in the Academy is housing, tenancy, and sustaining services. So these services align really well with services that those of you that are providing permanent supportive housing, rapid rehousing, transitional housing, even interim or bridge housing. These services related to helping someone to understand their rights and responsibilities as a tenant, to link with community resources, to have a good relationship with their landlord, with their neighbors, any prevention strategies when you identify things that might be barriers to someone staying successfully housed. Those services could be reimbursed by the Medi-Cal managed care plan as a housing, tenancy, and sustaining service if you have a contract with the Medi-Cal managed care plan to provide that housing, tenancy, and sustaining service, and if the member is deemed eligible and is authorized for that service. So,
Cheryl, what do you think about
yes,
maybe taking like a brief
sure.
5-minute break just for folks to kind of reset? We're
Yes,
5 minutes
I've been
after
talking.
the hour, and it's a lot of information, right? And everyone's at different levels of it. But just to take a
I love
breath,
that
stretch your
idea.
legs, get some more caffeine so we can keep going.
And maybe
Um,
grab lunch for those of you that didn't get lunch yet.
yeah, so we're at 2:05. Why don't we come back and what do you say, Cheryl? Do you want to do 2:10 or 2:15?
Let's do, let me look at the number of slides we have left and then we can just, let's do 2:15.
Yeah, let's give us
We're
some
on
time.
the last
Give us
end.
some time to think about what we just heard and maybe even drink some support to help us get through the end. All
Thanks, Ambrosia.
right, we'll be back at 2:15, you guys. Take a break, take a break.
or reporting. Thank you, Ambrosia. Some sort of funding or reporting that then goes back to the COC and back to HUD to say, here's how we've spent the money. Here's what we've used, who we've served, how they've been served. This is the progress and the outcomes. That is the grants world where typically funding happens upfront and then maybe quarterly or once a year, twice a year, maybe even monthly, but it's usually an upfront payment that allows you to then have the funds to hire staff, pay your staff, provide the services you need. Medicaid is a reimbursement system. And before getting reimbursed, there are a number of steps that an agency has to take that require staff time, require sometimes legal expertise or consultants to help you to even get to the stage where you're ready to contract with a managed care plan. So the first step typically is that provider enrollment piece. This might mean for the state, it might mean that there are certain things you have to do, like getting a national provider identifier number with the Centers for Medicare and Medicaid. That is essentially a 10-digit number that then allows for payment and for tracking of the claims that you submit. Then many times with managed care plans, the contracting process, they want to understand your workflow, your policies and procedures, your staffing structure. They'll offer you a rate for your services. You might go back and forth on negotiating what will cover your costs for providing those services. You may want to add some things into the contract that guarantee a certain number of referrals per month so that you can keep staff on and ensure that you have enough people served. So there is a good amount of time that goes into that provider enrollment and the contracting process. Then, as a Medi-Cal provider, you can provide services to people who are enrolled in Medi-Cal and who are authorized for that service. So what does this mean? It might mean that there are some people who you are serving who are 100% eligible for Medi-Cal, but their enrollment has lapsed. Or maybe they never enrolled with Medi-Cal, even though they meet the income requirements or they meet the disability requirements. So they aren't on the radar of a Medi-Cal managed care plan. That plan doesn't know their name, doesn't have information about them. Isn't concerned if they get services because they are not a member of that plan. The minute that someone is enrolled in Medi-Cal, for the most part, they will be assigned to a managed care plan. And they also have the option to change managed care plans. So when someone is enrolled in Medi-Cal, that does not yet mean that they are eligible or they are authorized for community supports. There has to be a referral and an intake or assessment done and submitted to the managed care plan, which will give information to the managed care plan for them to make the determination if this person is authorized to receive those services from you. So again, all of this time and these activities are not paid for. So this is where startup funding and having other grants to cover those costs is going to be really important. Once someone is authorized for a service, you will then receive information that they have been authorized for the service and the authorization time frame. So in some cases, a managed care plan will say we authorize services for 12 months. In other cases, they might authorize for 180 days. And there's an expectation that as the provider that you are tracking who is authorized for services and who isn't, and that you know when someone's authorization is expiring so that they can get reauthorized. Because if an authorization lapses and you continue to provide a service, you will not be paid for that service when the authorization has lapsed. For those of you that are working in counties where the county is managing this administratively, you don't have to worry about not getting paid because the county has other local funds that they may pay you from. But for those of you that are going to be or thinking about contracting directly with a managed care plan, Having systems in place to track authorizations and start and end dates is going to be really important. Being able to track which of the people you're serving are enrolled in Medi-Cal, have active Medi-Cal, and are authorized for services is going to be essential for you to know that you will be getting paid for those services. So then you're at the point where you can actually provide services to individuals, the part that we're all here for, and what really drives our hearts, right? After that, there are steps that will need to be taken that might be new for how you document the services provided. And again, this varies by managed care plan and how they are expecting the documentation to be stored, if they want to see documentation for every time you see someone, or if they will ever come to your office or agency to do an audit of documentation. It really varies by managed care plan right now and how they're rolling them out. But there are some expectations and standards that we'll share with you in the documentation session that will be really important for you to know to get prepared for. And even if your agency is not thinking about contracting right now for community supports, I would advise you to think about how far is your current documentation process away from the expected Medi-Cal, Medicaid standards, because that can help to give you a sense of timeline in terms of quality improvement and working toward getting to that documentation standard that could then mean Medi-Cal reimbursement in the future. So at that point, after services are provided and they're documented, from that documentation, claims or invoices are created and submitted to the managed care plan. And at that point, then the managed care plan has 30 days to pay 90% of the invoices and up to 90 days to pay all of them. If for any reason something is deemed as not a good claim, so not a clean claim where there's a mistake, maybe the wrong date was entered and it doesn't match with the authorization time frame, or a number was incorrectly entered and so that Medi-Cal number is not correct, and so they're saying they won't pay this claim. You will then, as a provider, have time to go back and work on cleaning that claim up, correcting it, and resubmitting it. But what I'm wanting to show with this timeline is that really impacts your cash flow. And so all of that time when you're waiting for services to be paid back, you still are paying staff salaries and you still are having all of your other operations costs. So we have a budgeting tool that we're going to introduce in the Money Matters #1 session, and then provide technical assistance for all of you, because it's going to be really important that you ensure that there is time for this ramping up of getting people enrolled in Medi-Cal, getting them authorized for the services, and then time for the documentation and claim submission and waiting to receive reimbursement. So all of that, you'll want to have a startup fund for that. So there are 4 different bucket areas that the Academy is going to be focusing on. The next session is on business planning. So that's really heavily sitting in that strategic bucket. It does sit a bit in programmatic as well, because we're going to be talking about looking at your agency mission and the people that you serve currently, and thinking about your staffing models, and do they align with the staffing models and the rates that are being proposed by the managed care plans, and do the people that you serve align with the eligibility groups that the managed care plans have on their website. We'll be talking about long-term planning and what it might mean to have a business plan that's for several years, and thinking about what funding you might need to bring in and what partnerships you may want to start working on now if you're thinking about subcontracting rather than contracting directly. The sessions that are on quality improvement, finance, operations, and compliance requirements, those are later on this spring. And the reason for that is that we're trying to upfront the Academy with those for people that are right now in these beginning stages. And then for those that are in operations right now, we want to provide you with the tools that you can use to have this continual quality assurance, quality improvement, and compliance. But as I said, many of the managed care plans are still figuring this out on their end. So we are working with those managed care plans across the state to learn as they roll out new expectations. Many of them have some short-term standards and then have an idea of long-term standards where they'd like providers to get to. And so right now there are more exceptions being made in terms of how invoices are submitted or what's considered a claim that may change over time to better align with traditional Medi-Cal and Medicaid standards and practices. So the last of the sort of 10,000 foot view that I've talked about, but I want to just highlight this slide, is that there are multiple ways that you could be reimbursed for offering these community supports. It might be through a subcontract, or it might be with a direct contract with a managed care plan. And that would mean different administrative tasks and different levels of risk. So again, if you have questions about where your county is at or what is happening with the managed care plans in your area, please feel free to email us at medicalacademy@csh.org, and we can then answer more specifically for your agency. So before we open up for questions, I want to give this 10,000 foot view of some of the considerations that each of our upcoming sessions will walk through in greater depth. So this is that 10,000 foot view. We're in an airplane and I'm like, there's some mountains, there's a field, that's a swimming pool, but we're not actually digging into any of these just yet. Really wanting to understand what would be a competitive and sustainable rate for your agency. It's going to vary agency by agency. We cannot tell you what would work, but we can give you tools that would help you to dig into and understand what it will cost you so that you can then have the information you need to negotiate for a rate that would help you to sustain activities and sustain your staff. We're going to dig into the supplement, not supplant language that is in nearly every federal grant contract. There is language that this can supplement services, but not supplant. And so when bringing in Medi-Cal funding, when you are also being paid by other federal sources like HUD, there's going to be a need to demonstrate how this new funding is helping add to your programs and not replacing funds. So we'll talk more about that, and then also thinking about grading and blending and maximizing your funding sources so that you have some that are extremely flexible and can fill in the gaps, and others that may be funding core activities. And then this final section, identifying your capacity and your bandwidth. There are lots of questions that the next few sessions are going to be asking around in business planning, what aligns with what you're doing right now? What capacity do you have to add a new program, to bring on new staff? Would you be needing to hire new staff for compliance activities, for claims and billing? Are there new activities for your finance department that would require an additional person? What about data management and data systems? What will that cost? So there are a lot of questions that we will be either giving you tools and templates to help you in answering that, or the types of questions and referrals to other TA providers who work specifically in those areas. I think the last thing I'd want to highlight, and then we will open it up for questions, is just this inclusive decision-making process and the importance of bringing in frontline staff and people who you serve into the process early on. My first job in supportive housing was with a mental health provider that billed Medicaid for housing related services. And what that meant for how we did assessments and how we documented services, HIPAA, which is often posed as sort of the scary compliance, you can't share information because of HIPAA. As a HIPAA covered entity, it does give program clients a lot of rights. around being able to see what is documented about them. What you are providing is a part of their legal medical care, and it's a part of their legal medical record. And so HIPAA gives those individuals the right to have a say in what is documented about them. They can ask to view it at any time. And so it really changes operations and the administrative burden on frontline staff for how the time and care that they take in documenting each and everything that they do, because it really is now a part of an individual's medical record. So because of all those changes for the client and for your frontline staff, having conversations early on about this is something we're exploring. These are the benefits. This is the revenue it could bring us. This is how it could improve our services. Is this something that we would be interested in pursuing? Having that as a conversation with your team and with people served is going to be important when thinking about entering into these medical spaces. So this is our 10,000 foot view. We'll be digging in greater depth. This is recorded. We will share it back with you. And these slides, anywhere that you see links in the PDF, they should be live links. So you should be able to click on them. And I'm going to hand it back to Ambrosia to walk us through the next slide.
Good afternoon. And we will definitely, like we mentioned earlier, have some space for some questions, maybe some feedback. But this is a great way for us to really gather from you guys some information on not only where you stand now, but maybe also what you need in order to take the next step. If that means preparing in the future to becoming a provider, or maybe starting the work now and understanding some of those elements that we talked about, like how your agency is impacted by cash flow and some of the service delivery impacts to your organizations, right? So help us help you. We have right here the QR code and also the link available for you to complete what we call an agency readiness and technical assistance needs assessment. We're estimating it might take you anywhere between 15 to 20 minutes to complete. And we do ask that you have one submission per agency, so pick a point person to complete this on behalf of your organization. And there's opportunity here for folks who get it done pretty quickly. So by January 18th, your organization could be potentially eligible for a prize from our raffle. So all entries will automatically be eligible for a raffle prize. It'll be a gift card for the organization, and it could look like maybe helping to fund lunch for some staff, or maybe some supplies for some hygiene supplies as an example for some of the clients that you're serving. So we're hoping that helps to get you through that process to complete and answer all those questions. And it also helps us to either provide TA to you directly if that's your organization situation with us, or to direct you to TA resources to support you on this journey where it takes you above and beyond the Medi-Cal Academy experience. So yeah, scan that code, or if not, I think we can also drop this link right here in the chat, and it'll be available on the slide as a live link when we send out the PDF versions of this as well. But if you can get that over to us by the 18th, we would love to see where you are and what you need. So thank you.
And I will say that the statewide TA marketplace is something that the Department of Healthcare Services is putting together to have one-stop shop sort of place where any provider can go and request technical assistance. That would be free technical assistance paid for by the state. The state has been gathering a network of technical assistance providers for the different community supports and enhanced care management. That is supposed to go live at the end of this month. So if there are any TA needs that we see on here, on your readiness assessments that we might not be able to provide support to you with, we will absolutely make sure that you get the information about the TA marketplace. And if there are any TA providers that we know of outside of the marketplace as well, there is a lot of funding coming right now from foundations and from the state to fund technical assistance, because there is so much startup time that's needed to get to the place where you actually are getting reimbursed. And so there's a lot of technical assistance opportunities that are just about to start. We were told in January, and now it's looking like they're saying January 31st that the marketplace will be live. So we will keep you posted on that as well.
So I like that we have this acronym REACH. So we're reaching for maybe what our next steps will be, reaching maybe towards this goal of becoming a provider if it looks like a good fit for us, right? So our first R here for REACH is read, right? So we have here linked the community supports policy guide to dive deeper into the specifics around the services that you could potentially be reimbursed for, and some of the eligibility guidance is critical, right? If we're at the very beginning. So we want you to take a look at that link. Again, we'll send all of this out to you guys post-training. You can click on these. We also want you to explore maybe potential funding sources, right? So we talked about the fact that organizations may need seed or startup funding. So looking at the Housing and Homelessness Incentive Program link that we have provided should tell you something about how managed care plans may be incentivized to do really well with their social determinants of health and the outcomes from the populations of focus or that they're targeting, right? And so as an organization, especially if you're contracting with managed care plans, it's great to know what the goals are for each plan so that you can be well positioned to share with them as a provider that you're the expert in that you can help them achieve those outcomes. And maybe those funds can be shared or passed down to your organization as a result of you helping them to meet those goals or targets that they've set. I don't know if you had more to share about that, Cheryl. Also, the enhanced care management community support opportunity. There's some additional funding resources you can check out on that link. PATH funding is always something to consider if your organization is not already a PATH funded provider. And then, as Cheryl mentioned, that TA vendor marketplace for this, there's some free TA potential is coming soon. They should be opening up the application at the end of this month so that you can get the support through this transition above and beyond this academy. And then we have the A, we have attend. So for folks who are at that earlier stage who are still making this decision, the next session is for you. This is the business planning session where we'll be talking about business planning. We're talking about cash flow and projections, and just maybe some considerations around the process of contracting with a managed care plan or a county. So if you're at that beginning stage, if you're still trying to make this decision, if you're still trying to figure out what are some of the cost benefits and weighing that, this business planning session is for you. And so that's on the 25th. We have the Zoom link here, but folks should already have access to all of that by virtue of being in our Medi-Cal Academy. But we just want to make sure you knew when and where. The reminder, what's next. Also, we want you to complete our T and needs assessment we just shared with you, right? And we want that, hopefully, everyone can get that done by January 18th. Again, there's incentive, maybe a prize involved for you guys, for everyone who can get that done for us by that date. And then also consider signing and supporting our Supportive Services Transformation Fund. Really, CSH has worked together with some partners to really elevate and push for some changes around how funding is structured and made available so that it isn't so burdensome and so hard for organizations to fund the supportive services that are necessary to support people to stay in or access first and then stay and maintain their housing, right? And so you can learn more about that opportunity, consider signing on and supporting that initiative as an organization so that we can have a better process, better means of managing and allocating funds. And the next thing we're going to do is have ready, our H here. So I think you can talk more about what this means, Cheryl, right?
Sure, yeah. So a few suggestions of next steps or things to have ready before the business planning session if you're planning to attend. If you are not yet tracking the Medi-Cal enrollment, or if people you're serving are enrolled in Medi-Cal, I'm going to ask for you to think about having a guesstimate of the number or percent of clients that you're serving who you think are eligible for Medi-Cal. So one way to do that is looking at, if you have an understanding of income level, then you can look at the eligibility criteria around Medi-Cal for income level, or around disability status. If people are enrolled in SSI and receiving disability income, that is another way where it can help give you a sense of if someone would be eligible to enroll in Medi-Cal. if you do have the number or percent of clients that you're serving, if you are tracking if someone has active Medi-Cal or not, be ready to come with that number, because that's something that then we'll be able to do some simple equations to look at, what percent are enrolled in Medi-Cal, but do we think will be eligible for and authorized for community supports based on the managed care plan in your region. That takes me to the next bullet point. So MCP contacts. So if you don't yet know which managed care plans are operating in your county, there's a link that will take you to the managed care plan list of which community supports each managed care plan is offering. This is the latest list that was just updated since some of the legal settlements happened in December for San Diego and some other counties. So there are some additional managed care plans listed on there that weren't there before. And then the last thing I'll say is if you are not yet sure of the eligibility requirements or eligibility statements that the managed care plans have listed on their websites, once you know the managed care plans operating in your counties that you serve, then I'd encourage you to go onto their websites or do a simple Google search for eligibility, housing community supports, and they are required to, by the Department of Healthcare Services, managed care plans are required to have a publicly available website that states the eligibility expectations for who they are deeming eligible for community supports for each specific community support. So there may be a different eligibility criteria for people to receive housing deposits. That may be different from people receiving housing transition and navigation services. And it may be the same or different from the eligibility criteria for people receiving tenancy and housing sustaining services. So we'll want you to get familiar with your managed care plan and get comfortable with navigating their website and finding the eligibility criteria.